Competency-based medical education with assessments of specific defined curriculum has been in place in many countries across the world, and we have learned from these other countries' experience. We need to have specific unified assessment tools, such as the Surgical Skills Assessment Tool and the Professional Behavior Assessment Tool. We need to have a streamlined process that minimizes burden for those individuals that are performing the assessments. Australia, Canada, Great Britain, South Africa are all doing competency-based medical education, and so are we. It is so important that we embark on this program. The ABOS has spent the past 10 years validating the surgical skills assessment tools and the professional behavior assessment tools, and we are now ready to collaborate with the ACGME and go live with our KSB program. The mission of the ABOS is to protect the public. In order to do that, we establish the standards for education in orthopedics residency training programs. Competency-based medical education is the new gold standard. The American Board of Medical Specialties and the ACGME have both endorsed competency-based medical education as the premium method to be training our residents, and in our case, orthopedic surgeons. So it really was to be in the forefront in the United States for the American Board of Orthopedic Surgery to engage in the process of trying to set up a competency-based program for training orthopedic surgeons. The ABOS has led this initiative for competency-based medical education, but we do that in collaboration with the ACGME to try to decrease the burden so that both processes can be parallel and integrated. In general in medicine, we have been very good at measuring knowledge. This is usually measured with a standardized test, and we take lots of tests throughout our educational process. This was fairly well developed when we first started the KSB program. We have the orthopedic in-training exam throughout our residency training, and we have our Part 1 written examination upon completion of training. The main goal of the KSB program was to try to integrate the orthopedic in-training exam with our Part 1 written exam. This allows a resident who is in training to get a progress report as they progress through residency training on achieving a passing score for the Part 1 written exam. The ABOS has collaborated with the AAOS in linking the OITE to the ABOS Part 1 written exam. We have done this by writing 50 to 60 questions, which are given on the ABOS Part 1 exam, and we can see what a passing candidate does and what scores they achieve on these questions, and then have the same questions in the OITE exam that year. That way we can link the two exams of what the scores would be on those 50 to 60 questions in order to achieve a passing score on the board's Part 1. This is not a fail-proof scoring system, but it gives a good progress report to your knowledge acquisition during residency training as you work towards competence as measured by the Part 1 written exam. As an orthopedic surgeon, we need to be able to measure ability to perform surgery. We need an assessment tool. The OP tool is a tool that has been validated, it has been published in JBJS, and it has been shown to track progression from a PGY1 level through a PGY5 level and documenting when a surgeon becomes competent and not just a time-based program of where they are. It is important that the resident knows to request the surgical skills assessments, not just when you've achieved competence, but as you're tracking and progressing towards competence. It is an educational tool to track your progress as you continue to gain the skills to become a competent orthopedic surgeon. One of the things about our previous time-based system was that residents would get feedback at the end of 6 weeks or 3 months or maybe even 6 months. The surgical skills assessments is a real-time assessment. This has been validated and studied in the general surgery literature using the SIMPLE tool. It is much more effective to have real-time feedback on specific operations than it is to have summative feedback at the end of 6 weeks or 3 months. When we first designed the assessment tool, we had a longer portion that was formative and a shorter portion that was summative. I thought the faculty would love the summative thing, one question, but the faculty overwhelmingly liked the formative feedback. They liked the ability to be able to give the resident more extensive feedback about areas that they were doing very well in and areas that they needed improvement in. Generally, our faculty has had 80 to 90% completion rates. The rate limiting step has been the residents requesting the surgical skills assessments. In the past, I used to get an end of rotation, and I would have 25 questions, and I could hardly remember for sure which resident did what when. At the present time, at the end of a case or at the end of the day, I get a surgical skills assessment from the resident that I worked with that day. As a faculty member, when I get a surgical skills assessment, it is very easy to fill that out. The first question asks about the complexity of the case so that it can be modulated if it was a very easy case, a normal case, or a very hard case. There are then 8 questions about the 8 different domains during the surgery itself, including visual spatial skills, their preoperative plan, their knowledge of the steps of the procedure, and it is those types of questions that give nice formative feedback. The last question on the surgical skills assessment asks for a summative assessment. Is this resident operating at a novice, low intermediate, high intermediate, a competent level, or advanced expertise? And finally, there is the feature of being able to give some formative feedback by, most commonly, I would dictate, because it's very easy. You push the dictation button, and just like if you're dictating otherwise, you can give a nice summative feedback on what they did well and what areas of improvement. And this is what our residents like most. It has been shown by the general surgery group that better feedback is given within 72 hours because the faculty member can remember the details. It is allowed to do assessments up to 2 weeks afterwards, but frankly, you start to forget the details. When we set up the validation process, we looked at it under 2 different circumstances. One circumstance was end of rotation, and the other circumstance was in what we call a 360 push. In the end of rotation, the resident requested the professional behavior assessment and could be cherry-picked by the resident. In the 360 push, this was sent out in a 360 evaluation format to multiple individuals who are in the working environment with the resident. We tried to look at the comparative results between professional behavior assessments that were done at the resident request versus at the 360, and they showed different but important information. Because of that, the ABOS has decided to include both the end of rotation, as requested by the resident, as well as the 360, when we designed the professional behavior assessment tool for the ABOS. We looked across multiple literatures in professionalism, and there were 5 main domains which were identified. Each of these 5 domains has specific descriptions about the professional behavior competence that we are trying to assess. When someone has a deficiency in one of those areas, that way an intervention can be targeted towards the area of deficiency. Let me give you an example. If a resident is deficient in reliability, and you read the description of reliability, it means being on time, following up on your notes, being able to be reliable for the attending to carry out patient care skills and other professional activities. This gives specific feedback to the resident to say you need to increase and improve your reliability. So in each of the 5 different domains, feedback can be given depending on the assessments that are given and the scores to identify areas of deficiency as well as areas of excellence. Resident education is adult education. In adult education, it is the resident themselves that is responsible to make sure that they are getting the appropriate feedback as they progress through the program. This is a resident-driven program.